30 seconds, preferably 60 seconds, in my opinion. So there are a number of recommendations have been made by different societies around the world. American College of Obstetrics and Gynecology recommends delayed cord clamping for at least 30 to 60 seconds. That's half to 1 minute in all infants, preterm or term infants whenever possible. Royal College of OBGYN delayed cord clamping for 2 to 5 minutes in healthy, term, and preterm babies. ILCOR recommends European Resuscitation Council at least 60 seconds for babies not requiring resuscitation. This is area that is currently being studied. In my opinion, again, in my opinion, babies that require resuscitation are actually the ones that do need delayed cord clamping. So it's better to start resuscitation and then clamp the cord. So I will show you in a minute about that. European Academy of Perinatal Medicine recommends delayed cord clamping for at least 30 to 35 seconds. Canadian Society, whenever possible, delay the cord clamping by at least 60 seconds. WHO, in preterm infants who do not require positive pressure ventilation, delay the cord clamping for at least 60 seconds, and in term babies, 1 to 3 minutes. Because iron deficiency anemia is very common in low and middle income countries, and therefore, which is a major factor in impacting the neurodevelopmental outcome in lower middle income countries. That's the reason they recommend in term babies, you can wait for as long as 3 minutes. European Society for Pediatric Gastroenterology and Nutrition Committee also recommends delayed cord clamping for all infants. In Italian Society, recently in 2018, updated their guidelines and said delayed cord clamping for at least 60 seconds, tactile stimulation to encourage spontaneous breathing. So some people call this physiological-based cord clamping. So when do you say yes to cord clamping? A mom with HIV, can we allow delayed cord clamping? As long as the viral load is less than 1,000 copies per ml, I think it's recommended. In dichorionic twins, it's recommended. Neonates with congenital heart disease, it is recommended. Cord blood banking, even if somebody wants to bank the cord blood, you can still do the delayed cord clamping. And if you want to get cord blood gases, it can still be obtained during delayed cord clamping. There is really no contraindications to delayed cord clamping, absolute contraindications. Monochorionic twins, there's some data that suggests that it is safe. There's a study published from California that said you can do it in triplets, twins without any risk. Twin-to-twin transfusion syndrome documented. I think these are relative contraindication. Asphyxiated babies, not sure what we should do, but I think there is more studies are ongoing. Fetal hydrops, maternal cardiac arrest. What about in IUGR babies, intrauterine growth restricted babies? It's still question mark, but a lot of people continue to promote delayed cord clamping. Let's go to resuscitation. So the baby comes to you, delayed cord clamping, what do we do? Baby has respiratory distress. We do bag and mask ventilation, right? That's the NRP recommendation, and many societies recommend that. So the problem with that is even in experienced hands, this is an excellent study published by Dr. George Smalser from Canada in 2011. Neil Feiner from San Diego also published a similar paper in a mannequin, but this is in real babies, preterm babies in the delivery room using a respiratory function monitor. They continuously recorded the pressures, gas flow, and tidal volume. You can see using a face mask during resuscitation resulted in airway obstruction, defined as a 75% decrease in exhale tidal volume and 26% of the time, and leaks that required readjustment to get the tidal volume back happened 50% of the time. So you can see that in the middle of resuscitation, you need to make all these adjustments, which is not very good. Another interesting study just got published last year in the Resuscitation Journal, which is the European Resuscitation Council Journal in 2019 from Netherlands, TPAS et al. Effect of face mask on breathing and heart rate and saturation less than or equal to 32 weeks. So they can see that when the positive pressure ventilation was given using a face mask, the number of times these babies became bradycardic, stopped breathing 79% of the time, compared to 16% that continued to breathe. They give sustained inflation 77% of the time. And so they said applying a face mask over the baby's nose and the mouth area triggers what is known as trigeminal cardiac reflux. This is well known in adult patients. For the first time, they documented this trigeminal cardiac reflux leading to apnea in 54% of the babies, bradycardia, and desaturation. The study that whether avoiding sensitive area around the mouth and by using alternative interfaces like nasal prongs would decrease the risk of inducing trigeminal cardiac reflux. So two problems with face mask. One is the leaks and airway obstruction, even in experienced hands. Two, this trigeminal cardiac reflux, not many people have discussed. I'm so happy that they did the study and published it last year. So in our center, we use the RAM cannula. This is a drawing by Professor Satyan from UC Davis. He's an outstanding neonatologist, actually a brilliant neonatologist, and he's excellent in drawing and making things simpler for everybody to understand. So I asked him to draw these figures for me. So with this is the face mask. I told you mask leaks happen, obstruction happens because the soft tissue is displaced towards the hypopharynx or the glottis area. And if you put the RAM cannula, there are no leaks, and you can bypass the oropharynx, and thereby you can actually decrease the dead space. There's a lot of gas when you mask goes into the oropharynx that does not take part in gas exchange. Whereas if you're using the nasal prongs or the RAM nasal cannula, all the gas that you're pushing in goes into the hypopharynx and then glottic area and into the lung. And now I have another reason. There's no trigeminal cardiac reflux, and the chance of bradycardia or apnea are less, and of course, much easier to use. We published an observational study from our NICU many years ago, my colleagues, Dr. Biniwali and Dr. Wertheimer, in babies less than 1,500 grams. We were using face mask and CPAP in the delivery room, and then we started to use RAM cannula and NIPPV. So we compared historical controls versus after we implemented NIPPV using the RAM cannula. You can see birth weight is similar, gestation age 27 weeks. Number of babies required intubation when we were using face mask and CPAP was 85%. Compared to 31% when you start with NIPPV. And again, we use the RAM cannula. Delivery room emergency intubation was significantly lower, 29% versus 68%. Number of babies needing chest compressions were also low, 31% versus 11%. Even number of babies who got intubated because failed resuscitation was higher, 66% compared to 38% in the NIPPV group. That's why that has respiratory distress. I always start with NIPPV using the TPs in the delivery room as my primary mode of support. And then the baby doesn't need NIPPV, then I just leave the baby on nasal CPAP. Duration of invasive ventilation is 11 days compared to 2 days. So even when the baby required intubation in the delivery room, I can extubate the baby back to NIPPV much sooner and avoid invasive ventilation. Both groups had significant RDS and got treated with surfactant. 90% of the babies received surfactant in the NICU. I do not recommend, and we do not use prophylactic surfactant therapy in the delivery room. I think your focus should be on more and more on resuscitating the baby, stabilizing the baby, avoiding hypothermia, move the baby to the NICU, and controlled settings, you can give surfactant using Insure or LISA method. And you can use that. But if you have an NICU close to the delivery room, then you should bring the baby to the NICU, and then within 30 minutes to 2 hours, you have plenty of time, 1 to 2 hours, you have time to give the surfactant. Here is a similar experience in babies over 1,500 grams, CPAP with face mask, NIP with a RAM cannula, 769 babies. We presented the data. We haven't published this study. Again, it's an observational study, not a randomized controlled trial. Big babies, 2.8 kilos. 14% of the babies got intubated with face mask CPAP compared to 7%, and no other complications. Number of babies intubated at 24 hours of age, 17% compared to 7.6%. So typically, this is what we use in our NICU and in the delivery room for resuscitation. Okay, third point is oxygen use. How much oxygen should we use to FiO2 should we initiate to resuscitate babies? Number one, remember, oxygen is a drug. Oxygen is toxic, both preterm babies and in-term babies. Also, bradycardia, heart rate less than 100, or saturation less than 80 by 5 minutes of age is associated with higher mortality, more intraventricular hemorrhage, and poor neurodevelopmental outcome. So recommendations, there are a number of studies have been published. Ola Sackstad is one of the top scientists looking at oxygen for a number of years, 30 years or 40 years. Max Vento, Ramji from India, a number of other, Kapadia and other people from US have looked at, Julie O from Australia looked at that. So based on that, and recommendations are, if the baby is less than 28 weeks gestation, start with FiO2 of 0.3. 28 to 31 weeks gestational age, start with FiO2 somewhere between room air to 30%. More than 31 weeks, you start with room air. You don't need to give supplemental oxygen in babies over 31 weeks. So this is according to Professor Ola Sackstad. He gave a talk recently for a neonatologist in India. He recommended, and I believe in his judgment and trust and knowledge. He says start low, titrate up according to the saturation and the clinical response of the baby. We still really are struggling to see what is the best FiO2 to give to preterm babies. There is another trial that's going to be starting soon, or already going to start soon, Torpedo 2 trial in Australia. So where they're going to compare in preterm babies 30% or 60%. So we still don't know. I think best thing is to monitor the heart rate, monitor the saturation, and then adjust your FiO2. So many times when you start with 21% in babies less than 28 weeks, a lot of times these babies end up going up to 30%. So you could start at 30% oxygen if you do have a blender. I know in many countries they don't have a blender in the delivery room. Either they can give room air or 100% oxygen. That is the case, you should start with the room air and see how the baby responds. Again, ventilation, ventilation, ventilation. That is the most important part during resuscitation. So here is another paper. What saturation should I accept? So by Augusto Sola and Castillo et al., published many years ago in Pediatrics. They looked at all the blood gases and correlated saturation and PaO2. Is 85 to 93% acceptable? either in the delivery room or beyond the delivery room. And they showed that if you target this saturation range between 85 to 93, you pretty much avoid hypoxia as well as hyperoxia. If saturation is more than 93%, you see the number of times where the PaO2 is over 80 is 60% of the time, you're going to make the baby hyperoxic, compared to 4.6% of the time if you accept a range between 85 to 93. So that's one of the reasons why I use lower saturation in the beginning, 85 to 90, and then go to 90 to 94 when the baby is at 33 weeks. But I think in the delivery room, in a preterm baby, there is absolutely no reason to shoot for target 95 or 100% saturation. Okay? The baby is on room air, desaturating 100%, that's okay. On supplemental oxygen, I really see no reason why you should target anything over 92% or 93% maximum. Okay, so now delayed cord clamping is done. You resuscitate the baby, and now you use the appropriate oxygen, but the baby still has respiratory distress. You move the baby to the NICU. So you have number of ways to support the baby. So non-invasive ventilation, nasal CPAP or CPAP or NIPPV. Nasal CPAP, you can use bubble CPAP, or you can use a ventilator CPAP, or you can use an infant flow driver CPAP machine. Pretty much they're all the same. If you have bubble CPAP in your NICU, just continue to use that. If you're using a ventilator to get delivered CPAP, there is no difference in extubation failures, whether you use bubble CPAP or ventilator CPAP. There are randomized controls have been done, studies have been done. CPAP. CPAP is basically mimics CPAP. There are randomized controls comparing nasal CPAP versus CPAP or BiPAP and showed no difference in failures. So if the baby fails nasal CPAP, don't try to waste your time on trying CPAP. Just go to NIPPV or intubation. So the reason I say that CPAP or BiPAP fails most of the time is because the high pressure you can deliver is only about 15. In the US, 10 or 11. So the delta pressure, PIP minus P, is what controls how much tidal volume gets into the lung. It's very low, 10 over 5. That means 5 centimeters. If the baby has really high CO2, it'll be impossible to ventilate the baby. That's why they fail and with respiratory acidosis. NIPPV, on the other hand, truly mimics invasive ventilation and no endotracheal tube. You can use any pressure you want, peak inspiratory pressure. I start with 20 over 6. So I already have a delta pressure of 14 centimeters. I can easily ventilate the babies, okay? And short ride time, we normally use 0.5 seconds. High flow nasal cannula. That's becoming very popular because it's easy to use, and so everybody starts to do that. I do not recommend high flow nasal cannula because pressure is neither measured nor controlled by you. You have zero idea about how much pressure you're delivering. Not only that, even if you don't know how much pressure you are delivering, which may be the case with CPAP or NIPPV, because no one measures pressure at the lung level. All the studies were measuring at the hypopharyngeal level, right? But we can control. You set the PIP limit or you set the PEEP limit. It can never go more than that. Whereas in high flow nasal cannula, you cannot limit a pressure. That is the reason I do not recommend high flow nasal cannula in preterm babies. Even in term babies in my NICU, we do not use anything more than 2 liters per minute maximum. The other modes that are increasingly being attempted in an attempt to avoid intubation is nasal high frequency ventilation using nasal cannula, heated humidified high flow nasal cannula versus nasal CPAP in all babies less than 32 weeks. And it showed no difference in extubation failures and no difference in BPD, okay? And you can argue that there is no difference in BPD and no difference in extubation failures. So why not I use high flow cannula? I'll show you in a minute. In this study, Collins et al., they used 8 liters per minute. Manley, Australia, they used 5 to 6 liters per minute. Brady Yoder, 6 liters per minute. Brady Yoder from the United States, he used 3 to 8 liters per minute in their studies. I'm going to answer questions at the end of my talk, right? Because I see some hands going up. Okay, so here is a real world experience. What happens when you start using it in your NICUs? This study from Philadelphia, published in JAMA et al., 466 NICUs in their system, 2,487 babies, all of them were less than 1 kilo, less than 1,000 grams, extremely low birth weight babies, okay? You can see this is CPAP group, this is high flow nasal cannula group, this is high flow nasal cannula because it failed and then they ended up rescuing the baby with CPAP. Okay, they did multiple regression analysis to adjust for differences between groups. Okay, not a randomized controlled trial, but large observational study of 2,500 babies. Look at the rate of death or BPD. 50% of the CPAP only used, compared to 57% or 61% use high flow nasal cannula, failed, and then rescue with CPAP. BPD alone, 42% compared to 52%. These signs indicate p-value less than 0.05. Multiple ventilation courses, repeat intubations were much higher. 50% of the babies that were started on CPAP failed and got intubated. Remember that value. 50% of the babies failed CPAP and got intubated, compared to 65% or 53%. Number of times babies required intubation and re-intubation, 17% of the time, compared to 21 or 29% of the time. The babies who are on CPAP got intubated, got better, extubated, and then gets re-intubated because they're back on CPAP. That happened in 18% of the time. Days on ventilator, 18 days versus 25 days or even 30 days. Postnatal steroid use almost doubled for PPD. And days to room air, 62 days compared to 76 or 72 days. So the baby stayed longer on oxygen, longer on the ventilator, got intubated multiple times if they were using high flow nasal cannula. IVH is also higher, 11%, if high flow nasal cannula failed. PDA requiring therapy was also higher, statistically 4%. Fortunately, no increase in necrotizing enterocolitis, and ROP requiring laser treatment was also higher because babies were on oxygen for a longer period of time. Okay, length of stay, 82 days compared to 89 days or 95 days. So these are babies about 27 weeks, about 780 grams, okay, small preemies. So it doesn't seem to work. And that is the reason, because of the higher risk of death or BPD and longer length of stay, I generally do not recommend heated high flow nasal cannula as a primary mode of support in preterm babies. What about CPAP? Everybody likes CPAP, right? I like CPAP too. But what happens? These are 7 randomized controlled trials been published through 2013, from 2008 to 2013. Many of you are familiar with this, so I'm just going to show you the final points. Early mechanical ventilation within 5 days of life, first 5 days. So it's all these babies that were randomized to be on nasal CPAP in the delivery room. What happened to them in the first 5 days? So somewhere between 31% to 83% of the babies got intubated within 3 to 5 days after they were in the NICU. Okay, especially the support trial had the youngest babies, 26-week gestation, smallest babies, 835 grams. Mean birth weight, this is standard deviation. You can see younger the baby, younger the gestational age or smaller the baby, the risk of CPAP failure is very high. Sometimes people tell me, I don't know how to use CPAP. These are studies done by international leading scientists. Colin Morley from Australia, Rojas from South America, support trial from the United States. Vermont CurePap trial from Italy, Vermont Oxford Network trial from US and Canada, Gopal's trial from Germany, Canvas from Turkey. So in different parts of the world, in preemies, just using nasal CPAP will result in failures and needing intubation in a high percentage of the babies. What about CPAP versus CPAP? So this is Harish Kripalani's trial. Unfortunately, they called it as non-invasive ventilation. This is truly a trial of CPAP versus CPAP, largest randomized controlled trial, 1,009 babies, less than 1,000 grams. This is a pragmatic trial. And the reason why I don't call this, they call it as NIPPV, but I changed the title on this table to CPAP because 53% of the centers in this trial use CPAP machine. You cannot deliver NIPPV with a CPAP machine. You cannot get a PIP of 20. So even if you're using a ventilator in this trial, they recommended that maximum peak inspiratory pressure one could use 18. I told you I start a minimum of 20. And look what happened. Re-intubated post-randomization. 60% of the babies, whether you're on CPAP or CPAP, got re-intubated. Okay? No difference in BPD or death or BPD, absolutely the same. What are the interfaces that we use? Over the years, many have used prongs like Argyle prongs or Hudson prongs or Inca prongs or nasal mask, because sometimes the prongs cause nasal injury. We switch between mask and prong. And then out of the frustration, we developed a cannula called the neotegram nasal cannula. It's basically binasal prong designed to look like a cannula so that it's easier. With a standard 15 millimeter adapter, you can attach to a bag, attach to TPs, attach to a ventilator, conventional or high frequency. That's what we did many years ago. So again, when the baby's in the NICU, we prefer to use the RAM cannula for bubble CPAP or NIPPV or even nasal high frequency ventilation. We keep the baby's head and 20 to 30 degrees elevated to minimize water condensation going into the nostrils or oropharynx. And we use, everything else is the same. Again, thanks to Professor Satyan for this drawing. And if you're using bubble CPAP, it's the same thing. We attach it to the RAM cannula and the standard 15 millimeter adapter. So we eliminate the dead space. You wash out because the flow. You minimize nasal trauma, and you can maintain with the PEEP, the alveoli open. So these are things you are all familiar with it. So how do we start? We start with number one. If you are worried about using high pressures, peak inspiratory pressures, then NIPPV will fail. You cannot start at 12 or 15 over 5. That's CPAP. You will fail a lot. So you have to be using higher pressures because the resistance of the prongs or the RAM cannula is higher. So any non-invasive nasal interfaces, any nasal interface has high resistance. They're different depending on the size of the cannula or length of the tubing and prongs, right? So you have to use higher pressure. So we use 20 PIP, 6 PEEP, rate also we started at a higher rate, 40, and an inspiratory time 0.5 seconds. In BPD babies, we may have to use much higher pressures, 30 to even 38 centimeters. Many centers have routinely are using it. And because in babies with BPD, there is tracheomalacia and the expiratory flow limitation and airway collapse, we want to keep the airway stented open, so you have to use a higher PEEP. Some people have used even as high as 10. I normally use 35 over 10, 8, and NIPPV. The last few trials are primary support, CPAP or NIPPV. You can see NIPPV failures requiring intubation or re-intubation are consistently low if you manage a baby on NIPPV. 5 to 25% of the babies failed NIPPV and required intubation. So no more is going to give you 100% success. If somebody tells you that, they're not telling the truth. okay? It will fail, but much, much less. Statistically significantly less need for intubation in every single study. Lista study from Milan, Italy, there was not a statistical difference, but you can still see a trend, okay? And in 2012, we published another paper, very similar to what we saw in 1999, okay? So there is systematic review and meta-analysis of all the studies, whether it's synchronized or non-synchronized. This is Ferguson et al. From Melbourne, and Professor Lex Doyle also was a co-author, and Peter Davis, Professor Davis was also a co-author on the systematic review, and they show that respiratory failure by method, synchronized or non-synchronized, is lower. Even with non-synchronized, the risk ratio is 0.64, confidence interval 0.44 to 0.95. So if we have synchronized NIPPV, you can use that. If you don't have it, it is still better. You can use non-synchronized as long so that you can avoid intubation. Okay. Our goal is to safely avoid intubation and invasive mechanical ventilation. Right. We know the baby is intubated, you're likely going to increase the risk for BPD. So I'm so happy that they put Kripalan's trial as a mixed trial, because I told you this is not a true NIPPV and not truly synchronized, and therefore they called it as mixed NIPP mode. Again, they looked at what are the things that are interventions that have been shown to improve successful extubation. So they looked at nasal CPAP versus head box or oxyhood. Number needed to treat is 6, okay, to avoid. So if you're using head box or oxyhood, you should probably switch to CPAP because you're going to fail more often. Nasal CPAP versus high flow nasal cannula, no difference. Okay, methyl xanthines, yes. If you want to use caffeine, for example, it will clearly decrease the risk of failures, extubation failures. So many centers, at least in preterm babies, less than 1250 grams or 1,000 grams for sure, caffeine is now routinely used from day one to minimize the chances of failures. Doxaprime, no difference. NIPPV versus nasal CPAP, clearly a big difference in favor of NIPPV. 8 babies, number needed to 8 babies. Okay, very narrow range, confidence interval, 5 to 13 babies. Non-synchronized NIPPV versus BiPAP or nasal CPAP, you still number needed to treat is 8. Again, synchronized or non-synchronized really doesn't matter. So they concluded that preterm infant should be extubated to non-invasive respiratory support. Caffeine should be used routinely, and NIPPV is superior to nasal CPAP. Here's another systematic review of 10 studies, about 1,000 babies, early NIPPV in the first 5 days versus nasal CPAP. In this Cochrane review, they showed that early NIPPV does appear to be superior to nasal CPAP alone for decreasing respiratory failure and the need for intubation and endotracheal tube ventilation among preterm infants with RDS. I think there's more and more data coming up now and showing us that you should start with NIPPV in preterm babies less than 1 kilo, especially in the first 3 to 5 days. Then you can switch the baby to nasal CPAP if they are stable. The lung is more vulnerable to injury during the transitional period. So if we can avoid mechanical ventilation invasively in the first 5 to 7 days, you're already protecting the baby's lung. Here is again, what is the device in synchronization in this systematic review? Lemry et al. From Canada. A ventilator-generated NIPPV is the best. Number needed to benefit is 13 babies. Okay, so CPAP machines or BiPAP machines are not good. Whether non-synchronized or synchronized, even non-synchronized, you can see confidence interval is less than 1. Okay, so device by which you deliver NIPPV is important. Synchronization is not that important actually. Physiologically, it's nice to have synchronization. If you have it, use it. If you don't have it, don't worry about it until engineers come up with a better synchronization method. So here is another paper, Ramasamy and Christoph from UK published the paper just this year in August in Pediatric Pulmonology. So they looked at efficacy of non-invasive ventilation for primary respiratory support in preterm babies. It's a network meta-analysis, 35 studies, over 4,000 babies. And they concluded most effective non-invasive mode of respiratory support in preterm neonates with RDS was NIPPV. Need for mechanical ventilation with the NIPPV versus nasal CPAP, relative risk is 0.60. Okay. This is the most recent one, lots of babies and network meta-analysis. So how do we wean? Once you start on NIPPV, as I mentioned, we start at 20/6, rate of 40, inspiratory time 0.5 seconds. Wean the FiO2 less than 40, 2 less than 40, and the PCO2 is less than 60, and the pH is over 7.25. Then we start weaning the peak inspiratory pressure. Lastly, we wean the PEEP and then the rate. One baby is off NIPPV, 2 nasal CPAP, and the PIP is less than 15 or 12, PEEP of 5, rate of 20, and FiO2 is less than 30, you can transition the baby to nasal CPAP, and then you can get the baby off CPAP, and the CPAP pressure is less than 5 to low flow cannula. We generally like to keep the babies on CPAP or NIPPV until about 32 or 33 weeks post-menstrual age to promote lung growth. Remember, permissive hypercapnia also has been shown to activate glottic dilator muscle and opens the larynx in babies. This study was published in 1993. Okay. So wean PIP first. Do not wean the rate until you're ready to switch the baby to CPAP, until the pressures drop. And you don't have to wean the rate below 20. You can switch to CPAP. And we wean PIP by 2 centimeters every 6 to 12 hours, and typically not more than 8 centimeters in a day. And PIP is around 12 to 15. We wean the rate by again 2 to 4 every 6 to 12 hours, not more than 12 per day. If baby does not tolerate my weaning, I just go back to the previous setting and wait for 12 or 24 hours. Okay. In babies more than 34 weeks, weaning can be done faster. Here is fixing the cannula. So most important thing is have a gap. This baby appears to be very happy. Don't touch me now, right? So you can see this gap. Sometimes we use a duoderm to protect the columella, this part of the nose, to avoid nasal septal injury. And then you can let it float and then attach to the ventilator. You can also do that. This is one of our babies with a congenital glaucoma, big baby, and we used nasal. We use a orogastric tube to feed babies and use this tape to fix it. So you can use, say, the duoderm. This came off. This baby is sweating a lot. So the other thing that we do is if the baby got intubated and he's on high frequency ventilation, we do not switch the baby to condensed ventilation. When the baby is ready to be switched from high frequency ventilation to condensed ventilation, we straight away extubate the baby to NIPPV. Again, this is our experience. We have not done a randomized trial. And when we were doing high frequency to SIME and then to extubate, we call indirect extubation compared to direct extubation, which uses lower frequency and longer inspiratory time. For example, 3100A. You want to start at a frequency of, this is for nasal high frequency oscillatory ventilation. Instead of 12 or 15, you start at 8 to 10 hertz. And then IE ratio, we still keep it as 1 to 2. Occasionally, we'll go to 1 to 1. And peak airway pressure, very similar to what the baby was on CPAP or during IME. Amplitude is the 2 times the mean airway pressure. So mean airway pressure is 15, your amplitude is around 30. okay, twice. If you're using Draeger or Baby Log, again, 6 to 10 hertz, amplitude 2 times the mean airway pressure, IE ratio 1:1, and then peak airway pressure similar to CPAP or IMB. Leone Plus, they have a variable IE ratio. Stephanie or Sophie, which you have access, we do not have this in the United States, and we use jet ventilator rod. In general, whenever you use nasal high frequency, use lower frequency and longer inspiratory time. So the final part is surfactant. Surfactant has become the standard of care all over the world for babies with RDS, and there are a number of surfactants available. So what surfactants are good to use? So this is a systematic review, Cochrane review published in 2015. I think they included pretty much all the studies. You should look into that if you have want to read about it. So they concluded that risk of mortality before discharge, death or BPD, PDA requiring treatment, number of babies receiving more than 1 dose of surfactant in infants treated with Survanta or higher compared to Curocert. And they also looked at the differences in these outcomes was limited to studies using a higher initial dose of Curocert. So clearly, there are better outcomes when you use a higher dose of Curocert, namely the 200 milligram per kilo for the first dose. So they looked at 9 studies, about 900 babies, death before hospital discharge, number needed to harm, if you're using Survanta, is 20 compared to Curocert. Death before hospital discharge using a higher dose, 16 babies. Death or BPD, 9 babies. Death or oxygen at 36 weeks post-menstrual age with a higher initial dose, 7 babies. Okay, number of babies requiring more than 1 dose of surfactant, 7 babies. So every 7 babies, you end up using less dosing if you use 200 milligram per kilo for your first dose. PDA requiring treatment, number of studies are small. So in general, there are better outcomes with a higher dose of Curocert compared to Survanta. Remember, all the Survanta trials in these studies, they used only 100 milligram per kilo. There's another last year, Daniela Di Luca et al. From Paris did a systematic review. Now they had 14 trials in 1,491 patients. Okay, they looked at the outcomes, 200 milligram of Curocert versus bovine surfactants that includes Alveofact, Survanta, Infacert, or Cofactant. Okay, so any dose, you can see use of higher dose results in better outcomes. Okay, BPD or mortality was lower if they used a much higher 200 milligram per kilo dose. Very similar to the Cochrane review. Okay, so I think the data is clear that if you use a higher dose, initial dose, you get better outcomes. And they only approved that surfactant that you could use 200 milligram per kilo is Curocert. So how do we give it? Should we give it using the INSURE method, intubation, surfactant extubation, or LISA technique, using a catheter or a feeding tube? So 6 studies have been published in the systematic review. Again, all these studies were from Europe. So all of these studies, they used Curocert 200 milligram per kilo or between 100 to 200 milligram per kilo. They showed that if you use LISA method, you reduce BPD among survivors, death or BPD, you reduce CPAP failure or need for any mechanical ventilation. All of them are in favor of LISA technique. I think more and more people are now going towards LISA than INSURE technique and giving positive pressure breaths or keeping the baby intubated post-surfactant therapy for a brief period of time. Sometimes it becomes longer. The only side effect they saw was reflux of the medication was more common with the LISA technique. So you need to give it slowly when you're giving surfactant through a catheter or a LISA catheter or an angio catheter or a feeding tube. So LISA and NIV support mode. How can we reduce failures? So this study by Ankal et al. From Turkey in 2016, they compared babies. After giving Lisa, they switched the babies. They kept the baby on CPAP in one group and NIPPV in this randomized control trial. And they showed they used 200 milligram per kilo Curosur, mechanical ventilation via the endotracheal tube by 72 hours of age, significantly lower, 13% versus 29%. Overall need for intubation, 20% in the NICU stay compared to 37%. Surfactant treatment, more doses were required if you're on CPAP, less dosing if you're on NIPPV. Moderate to severe BPD is also a secondary outcome. Number of babies requiring 2 or more doses was 9 versus 10%. So clearly, if you give surfactant via Lisa technique and use a higher dose and keep the baby on NIPPV, you have much better outcomes. So here's another paper from Netherlands looking at how can we improve and decrease Lisa failures. There's 185 babies. So they looked at different factors. They showed if you use a lower surfactant dose or mother did not get antenatal corticosteroids, you're going to fail more often. And if the baby fails Lisa or missed, minimally invasive surfactant treatment results in severe IVH and need decreased survival and prolonged mechanical ventilation. So here is the study looking at if you use the dose less than 200 milligram per kilo first dose, Lisa failures are 63% compared to 85%. No antenatal corticosteroids, then failure rate is much higher. Even postnatally, you give surfactant. So that's why we always tell the obstetricians, please give, even if it's one dose, should give it because mom is in labor, she's fully dilated or 4 centimeters, you should give it. It's clearly beneficial to have the fetus exposed to antenatal corticosteroids. Of course, complete course is better. Inflammation, CRP, is more than 10 milligrams. Even the missed failures are higher. Higher FiO2 requirement before you give surfactant. If you wait for 40% FiO2 or 50% FiO2, you're going to fail more often. IVH grade 3, grade 2 or greater than grade 2, 3% versus 14%. So overall, survival without serious adverse outcomes is better if the baby can be successfully managed with Lisa. What can you do then? Use a higher dose, encourage the obstetricians to give more steroids. Okay, these are things that you can modify, so modifiable factors. Another modifiable factor from our study is that NIPPV. This is with the Insure, not even Lisa. We were doing Insure at that time. So Insure and then randomize the babies to NIPPV or CPAP. You can see if the babies are maintained at NIPPV, need for intubation is 23% compared to 58%. Secondary outcome, BPD was lower. Physiological BPD or oxygen at 36 was also lower. Need for additional doses was not different. So then finally, what FiO2 should I use before we give surfactant? What criteria should we use? I know European resuscitation, European RDS guidelines by David Sweet and others have changed the recommendation in the most recent 2019 to 0.3. There are 3 studies have been published. One from US, Tasmania and Australia by Peter Dargaville, and one from US, and the third one from Poland. 3 retrospective studies. They looked at the area under the curve. So a value of 0.5 means no predictive possibility here. So in all these 3 studies, they showed, they're all retrospective studies. The FiO2 of 0.3 in the first hours of life was a key predictor of nasal CPAP and associated with poor outcomes, both in babies between 25 to 28 weeks or 29 to 32 week gestation, okay, with an area under the curve of at least 0.8. So if the baby is on CPAP or on NIPPV and the FiO2 is more than 0.3, you should consider giving surfactant to that baby. Do not wait for it to go to 0.4 or 0.5 because you're going to have much higher failure rates if you delay your surfactant therapy until the baby gets to much higher FiO2. So in summary, encourage obstetricians to delay the cord clamping for at least 60 seconds. Use binasal prongs or ram cannula to resuscitate preterm babies needing respiratory support. And I told you the reasons. Support with NIPPV rather than nasal CPAP in the delivery room and in the NICU in preterm babies with respiratory distress syndrome or respiratory failure. Start with an FiO2 of 0.3 in preterm babies less than 28 weeks and target your saturation between 85 to 92 or 93. As I said, Professor Ola Saxlett said, you could even start at 0.1, titrate up or titrate down if you have a blender. Early rescue surfactant therapy using higher dose of surfactant like Curosur, 200 milligram per kilo, when the FiO2 is 0.3 or greater on CPAP or on the NIPPV. Thank you so much for your attention. We'll be happy to answer any questions.
Thank you very much, Professor Ramanathan. We are very happy with your presentation because this is really interesting and very practical. But now we would like to invite all of you to have the question. And before we have the question, I would like to summarize the presentation from Professor Ramanathan in Vietnamese. Chúng ta đã vừa mới
So before we start the Q&A discussion, I would like to have a few summary points for all the participants. So as we all know, this is a very practical topic on resuscitations of newborn baby, especially preterm babies. There's a lot of resuscitated premature babies. Nowadays, many of the hospitals in Vietnam, we are able to resuscitate and save a lot of premature and extremely premature babies. So with Professor Ramanathan lecture, we are all aware the benefits of delayed cord clamping, as well as the use of a nasal prong cannula and mask during resuscitations. Also, very important topic is about the oxygen use during resuscitations. So after hearing the 5 key points from Professor Ramanathan's lecture, I just want to summarize the few key points. From the lecture, we also know that for term baby, maybe you can increase the time for delayed cord clamping to 1 to 3 minutes, but for premature baby, it is recommended that we delay cord clamping for 60 seconds. And after the lecture, we also see the benefit of using the ram cannula for resuscitations. Have a lot of advantage in compare with the face mask, because there's a lot of leak during use the face mask. But with the ram cannula, the benefits is very clear, and this is also very easy to use. Another very important point is that now in our delivery room in many places, the CPAP and TPs for resuscitation is available in many places now. And we can see that the benefits of using NIPPV in compare with CPAP is very clear. And there's a lot of discussion about the oxygen level, and we start during resuscitations. Now, in most hospitals in Vietnam, we can control the FiO2 during resuscitations. So I want to point down here that we should always use the oxygens as low as possible, and we should start at 30% of oxygen for resuscitation. So, and the last point is using of surfactant for preterm baby. After hearing the meta-analysis, we can see that the benefits of using high dose of surfactant for preterm babies. So it is undeniable the benefits of using high dose surfactant for preterm babies, and combined with NIPPV, and it can gives a very good result for resuscitation of preterm babies. And in Professor Ramanathan lecture, we also hear about the benefits of the non-invasive high-frequency ventilation. Nghe thầy Giáo. Nghe không phải. So I have just summarized a few key points from Professor Ramanathan lectures. I think these 5 points are very practical and important for all of the neonatologists in Vietnam. So we have received a lot of questions from our participants. So now we will start the discussions. So we have a lot of questions here, so we will try to answer as much as possible.
And I had responded on the chat, but I didn't realize to the Vietnam Pediatric Association. So questions to the panel.
Okay, the first questions for Professor Ram.
Oops, I can't hear you.
Room air or 30% of oxygens for premature baby.
Yeah, so I already, as I mentioned, you know, from all the talks, all the review of recent studies and systematic review and torpedo trial, I think in babies less than 28 weeks, you could start at 30% oxygen FiO2. If not, you can start at 21%, but oftentimes you need to go up. So if you start at 30%, saturations come up to 85 and above, then just wean the baby to room air, you know, drop it back.
Thank you. So the next question.
You're cutting off.
The second question is, what do you think is the optimal ventilation mode in extremely preterm resuscitations?
Okay, so if your baby is not intubated, then it's NIPPV. If the baby is intubated, then of course SIME, and if you can do volume guarantee or volume controlled mode, that's probably the best. If you don't have that and the baby requires higher peak inspiratory pressure, some would consider in a extremely preterm baby intubated a peak inspiratory pressure of 18 centimeters. You should switch the baby to high frequency ventilation. Again, this is based on practice. Randomized control trials have not shown a difference. So if you have a volume control mode or a volume guarantee mode, you could use it. Otherwise, SIME pressure control with a volume limit.
Okay. Okay, the third question is that, is it beneficial to keep surfactant right in delivery room for extremely preterm babies?
No, not really, because your first goal should be resuscitate the baby. Okay. Second is to give surfactant. So therefore, do not waste your attention, focus, or time on getting the surfactant ready and prophylactic intubating the baby and giving surfactant in the delivery room. Use CPAP or NIPPV, use the appropriate FiO to avoid hypothermia, stabilize the baby, transition to the NICU or nurse or observation area to stabilize the babies. Then you give surfactant rather than rushing to give surfactant. There's absolutely no need to give surfactant within 5 minutes or 10 minutes or even 15 minutes. So just wait, complete the resuscitation, stabilize the baby, then give surfactant.
Okay. The fourth question. In case the baby is intubated and require cardiac compressions, what is the ratio of cardiac compressions and hand bagging if the baby is already intubated?
It's a good question. There is no good data or recommendations on that. So we still use same 93:1 compression to ventilation ratio like the NRP recommends, unlike the PALS recommendation. So if the baby's in the NICU and is intubated, there's a lot of debate. When do you start PALS instead of NRP? So many centers, NICUs in the US, that is not part of a freestanding children's hospitals, they continue to use NRP as their algorithm, they're intubated or not intubated. And then if your baby's in children's hospitals, some of them, if the baby is over a month of age, they will go to PALS. Again, NRP is mainly the reason. NRP is for respiratory failure, whereas PALS is mostly cardiac failure as in starting event, bradycardia, bradyarrhythmia, or asystole, or cardiac arrhythmias, whereas in NRP, the focus is mainly on respiratory failure. So we use NRP guidelines.
Okay, the fifth question is how to use the NeoPuff in resuscitation in preterm baby in the best way, the proper ways.
Yeah, so you set your pressures in the TP's resuscitator or NeoPuff at 20/6 in pressure. So the baby only needs CPAP, just use the CPAP of 6 centimeters. And the baby requires, because baby is hypopneic or desaturating, heart rate is not coming up, then use your finger and use approximately 40 to 60 times. And that pressure is 20 centimeters. And the baby chest is not moving and the heart rate is not coming out. You could increase the PIP pressure by increasing that yellow button to 25 or maximum of 30. So do not increase the flow rate. If you increase the flow rate in the middle of resuscitation, you will significantly increase the CPAP pressure or PEEP. So just adjust the yellow button to go up on the PIP limit from 20 to 25 or 28. So main thing is your finger, and do not hold the finger for too long. That is the inspiratory time. So even if you put 1/1000, that's 1 second. So take it off immediately. Put the finger down, take it off. Put the finger down, take it off. So don't hold it there, your finger. You will end up with pneumothorax.
The next question is that do we recommend delay cord clamping for extremely low birth weight babies with respiratory distress? And if yes, how do we perform that?
Yes, the answer is yes, but as I said, there are very few studies on that, whether how do we resuscitate and do delayed cord clamping at the same time. So if we can establish airway, so there are some tables available, commercially made. You take it to the next to the mom, and then you can keep the baby at the level of the uterus, and then have the baby on the resuscitation table, and you start resuscitation while the obstetrician waits for you to tell, okay, now 60 seconds, you can clamp the cord, and you continue the resuscitation. So you can do that. But there's very little data on that. Good animal data, some clinical data that supports so-called physiological based cord clamping. One that is when the baby starts to breathe, then the cord is still being, blood is still being sent from placenta to the baby. That's the best thing. It's not easy in some situations because we don't have the special table or arrangements, and we have not have enough space. And second, if the baby is in hypoxemic respiratory fetal distress, fetal bradycardia, I think better to take the baby to radiant warmer and you start the resuscitation.
The next question is that you can compare the effects of nasal cannula high frequency and nasal CPAP for premature baby after birth?
There are a few studies looking at nasal CPAP versus nasal high frequency. One from Canada, one from China, and 7 observational studies. They all said nasal high frequency ventilation is feasible and safe. Some showed decrease in the need for intubation, especially in bigger babies over 28 weeks. So under 28 weeks, we have very little data comparing randomized controlled trials, comparing nasal CPAP versus nasal high frequency ventilation. So at the present time, most centers use nasal high frequency ventilation as a rescue mode, not as a primary mode. You're on CPAP or NIPPV, you're failing. And how do we define failures? Typically respiratory acidosis with a pH less than 7.25, or the PCO2 more than 65, or repeated episodes of apnea, bradycardia, desaturations. Then you consider that as a NIPPV failure, right? Or CPAP failure. Then you can do nasal high frequency oscillation or nasal high frequency jet ventilation.
The next question is what is the difference of different type of surfactant for treatment of respiratory RDS?
I think, surfactant is a drug that has been very well studied from 1988 or 87, more than 40 years almost. So all surfactants work. But if you want to get based on evidence and based on randomized controlled trials, if you use a higher dose, like 200 milligram per kilo, that is not new. There are 5 studies published, same surfactant that you should use the 200 milligram dose, but it's a smaller volume. Babies tolerate better with Curosur. 2.5 ml per kilo dose is safe, and as including our own study showed that need for redosing or need for intubation were significantly lower if you use a higher dose. So that is the reason we recommend 200 milligram per kilo of Curosur for the first dose.
The next questions for you is, would you tell us about the current treatment of BPD in your NICU? Thank you.
BPD in NICU, we still have to use postnatal steroids. We use, if we have to use, we only use steroids if the baby is intubated, has evidence of BPD radiologically, and the FiO2 is more than 50%. No infection, no PDA, optimized fluids, then we use steroids. We use so-called like a DART protocol, low dose dexamethasone. We use even lower dose. So that's the management we do. In terms of ventilatory management, babies intubated, then the recommendation is just a low rate of 20, long inspiratory time, like 0.8 or 1 second, and high PEEP. Let's say baby's intubated, has bad BPD. Start using lower rate, longer inspiratory time, and higher PEEP. PEEP of 7 or 8 to keep the airway open and decrease expiratory flow limitation so baby can exhale easily and CO2 can be eliminated. So that's the recommendation from the BPD group in Philadelphia. They have a lot of experience managing BPD babies, and their recommendation is use low rate, long item, high PEEP. Those 3 things you want to remember. In addition to steroids.
So the next question is, after we resuscitate with the TPIS with the RAM cannula, which gestation age do you recommend to use IPPV for extremely preterm baby?
All baby. There's no even 22 3-weeker or 22 weeker. If the baby is stable on NIPPV, I keep the baby on NIPPV. If the NIPPV fails, then we end up intubating the babies. There is no gestational age cutoff for NIPPV. If NIPPV fails, then of course we intubate the baby. Before we intubate, nowadays we do nasal high frequency ventilation as a rescue mode. That also fails, then we intubate the baby and go to SIME. We do not routinely, just because of the gestational age, we intubate the babies. We don't do that anymore. We try to resuscitate and manage with a CPAP or NIPPV. If that fails, then only baby gets intubated.
The next question is, what is the your current practice on SpO2 target for preterm babies?
I use still 85 to 89 until the baby becomes 33 weeks post-menstrual age. Then I change to 90 to 94 until the baby is 36 weeks. Then after that, it could be more than 94% or 90 to 94% if the baby is on oxygen. So earlier on, I use low, later on, I use high. But if some people don't want to do that, I mean, there is controversy still. What is the best saturation? Some say you can do anywhere between 85 to 95. The neoprom group recommends 90 to 95 for all babies, and I do not agree with that. That's my own study we published and my own experience, and we do not. I don't like to keep saturation that high, especially with delayed cord clamping. Babies are having much higher hemoglobin. And if you keep the saturation too much, like 90 or 95, it may be toxic to the baby. So I don't like to use it. So I use lower saturation in the beginning and then high saturation after 32 or 33 weeks post-menstrual age. And if you don't want to do that, you can do 88 to 92 or 87 to 92 as one target, as long as the baby's on oxygen.
So the next question is that if we use caffeine for a long period, is it do any harm to the premature babies?
Not really. I mean, nowadays people are using caffeine like water. There are NICUs that send babies home on caffeine because they continue to have some apnea, bradycardia until 40 or 42 weeks. So I've seen in the BPD clinic that I follow, babies are sent home on caffeine. I normally don't, but there are other centers that are doing that. It's pretty safe drug.
So how long should a premature babies stay on CPAP?
Until about 32 to 33 weeks, because if we keep the lung stretched, it actually promotes lung growth. So even though baby may be on room air, no supplemental oxygen, we still leave the baby on CPAP until about 33 weeks or 32 weeks post-menstrual age.
The next question is why the delay cord clamping time in preterm baby is shorter compared to term babies?
Because most term babies do not have respiratory problems, right? That's where WHO recommended you could leave it for 1 to 3 minutes. But in general, most other recommendations from different countries and societies is 60 seconds, 30 to 60 seconds for both preterm and term babies. If you can delay it and the baby is otherwise breathing and crying, just wait for 3 more minutes so you get a lot more blood into the baby, so you can get iron deficiency anemia.
The cord clamping?
Yes.
And also the same questions from the same person is, can we use HFO? Can we use the RAM cannula for high frequency nasal high frequency ventilations?
Yes. No, first question is, can we use CPAP while the delayed cord clamping is happening? Yes, yeah. You can do that. If it's possible, you can do that because if you airway, breathing, and clamping, that's the new ABC. Okay, so chest compressions, you start with airway, ventilation, help breathing. C is clamping, cord clamping. So if you can do that, yeah, you can in preterm babies respiratory distress. If no respiratory distress, delay the cord clamping, and then you assess the baby in the radiant warmer or in the resuscitation table. But if the baby is having some difficulty, respiratory distress, and if you can start CPAP or even NIPPV next to the mom, where you keep a table to resuscitate the baby with a warmer on top of it, then you can do that. In terms of high frequency ventilation, yes, you can do nasal high frequency ventilation with a RAM cannula.
Sorry, your answer for the last questions is can we use the RAM cannula for high frequency?
Yes.
It's yes, right?
Yeah. There's no difference. Yeah, just attach the same ventilator circuit. Just use low hertz, long eye time, lower rate on the high frequency.
Oh, sorry. The next question is how do we do mouthwash and nasal wash during NIPPV and CPAP? Like how do you clean the nose and the mouth?
Oh, okay. So there's really no reason to clean the nose. So if there are some secretions, you can use a bulb suction for the nose. Mouth cleaning, nothing, just the bulb suction if there are too many secretions. We always use oral care with colostrum or breast milk. If it's available, we put a swab and on the cheeks and put breast milk or colostrum. It's a very good thing to do. If the mom has any colostrum, we apply every 3 hours in a Q-tip or with a syringe. Otherwise, your suctioning is same as CPAP babies.
Okay, so the next question is how many doses of steroids will be counted as already have steroid? That is the original question. So I don't know if it's clear to you.
Yeah, it's two. If it is betamethasone 2 doses, it's dexamethasone 4 doses is considered complete course of steroids given to the mom.
Okay, the next question is what are the difference in setting the MAP in nasal high frequency and intubated high frequency? And when should we use the nasal high frequency? Is there any difference in the mean airway pressure setting or other settings between the two?
Yeah, so the two major differences are if you are using nasal high frequency ventilation, use the lower hertz, lower rate, and longer inspiratory time. If you are intubated and high frequency ventilation, then use the similar settings that you normally do. IE ratio, for example, on the oscillator 1 to 2, hertz 10 to 12. So older the baby, bigger the baby, lower the hertz. Younger the baby, smaller the baby, smaller the lungs, higher hertz. So 10 to 12 in a term baby, 12 to 15 in a preterm baby, if it's intubated. If it's not intubated, nasal high frequency, then use from 6 to 10 hertz. Mean airway pressure is you typically add 3 to 5 centimeters above the mean airway pressure that the baby was on during conventional ventilation or during NIPPV. So those are the three settings: hertz, mean airway pressure, and IE time.
And when should we use the nasal high frequency?
Okay, so when NIPPV fails or nasal CPAP fails, then use nasal high frequency ventilation as a rescue mode. So let's say baby is on NIPPV and he has respiratory acidosis. You are not able to ventilate the baby. PCO2 is still more than 65. pH less than 7.25, then you switch the baby to nasal high frequency ventilation.
Okay, so the next question is, when do we consider to repeat another dose of surfactant?
Okay, so you gave surfactant to the baby and now he's 6 hours or 10 hours or 12 hours after the first dose and the FiO2 is gone up to 0.4 or greater, you should give a second dose. Most people use 40% FiO2 as a criteria for the second or third dose.
Liều surfactant. Do we use different pressures with ram cannula resuscitations and mask resuscitations?
No, we start with 20/6 with the ram cannula, and we pretty much they do with the mask too, same pressures in the delivery room. You just put the cannula, close the mouth, don't open the mouth, close the mouth with the ram cannula, and like this, see. You know, it's going to be like this when you're on the baby. And then use the T-piece. Or if you don't have a T-piece, you back the baby through the ram cannula, 20/6. It's very difficult to maintain that pressure with the bag and mask or bag and ram cannula. So that's why you should use T-piece. When the baby wants to breathe, he can breathe around the cannula prongs to avoid nasal damage, septal or mucosal injury. So I always recommend. Nowadays, the modern ventilators can leak compensate a lot. Very quickly, they will compensate for the leak. So turn the leak compensation button on. If your ventilator has leak compensation mode, keep it on. So that way, it will increase the flow rate to compensate for the leak.
The next question is, what is the recommended initial setting for volume currency mode? For example, what is the tidal volume, TI, and PEEP?
Okay, so the tidal volume is 4.5 to 5 ml per kilo is the recommendation, 4.5 to 5 ml per kilo. Inspiratory time, 0.4 seconds. Rate, 30. And peak inspiratory pressure, you limit it to 30. Ventilators should be able to deliver 4.5 to 5 ml per kilo tidal volume using much lower PIP.
The next question is about a different type of surfactant. So according to some data, there is some difference between different type of surfactant. For example, the prolactam, the original from pig, it is recommended is 1.25 to 2.5 milliliter per kilogram. But from boractam is higher, 4 milliliter per kilogram. And the synthetic original is 5 milliliter per kilogram. So can you comment on the dose of different type of surfactant?
Yeah, it's not the ml dose that's important. It is the milligrams. Kyrosurf is the most concentrated surfactant available anywhere in the world. Okay, it's 80 milligrams per ml. So when you are calculating the dose of 200 milligram per kilo for the first dose, use 2.5 ml per kilo. If you're using Survanta or Biractin, you have to use 8 ml per kilo. That's huge volume. And that is why no one uses 200 milligram per kilo of Survanta or any other surfactant. So you can use a small volume, low viscosity, higher amount of surfactant by using Kyrosurf. And that is why it is the most commonly used surfactant in the United States and around the world.
So the last question is about delay cord clamping, and I think they just want to once again clarify the definition of delay cord clamping. It means that we have to wait for at least 60 seconds, and then we cut the cord, right?
Yeah. At least 30 seconds minimum 30 seconds. So most organizations recommend 30 to 60 seconds. So if it is 30 seconds or more, then it meets the definition of delayed cord clamping. So minimum has to be 30 seconds, but most people will recommend you should do at least 1 minute, 60 seconds.
Professor Ram?
Yeah.
Okay, so there is a wondering about the milk cord.
Cord milking?
Yeah, cord milking. Can we use cord milking instead of delay cord clamping?
Cord milking is okay in bigger babies, but in smaller babies, less than 26 weeks or 27 weeks, there is some increased risk of intraventricular hemorrhage. So they recommend not to do cord milking. So just delayed cord clamping is safer.
Okay, we have a few more questions. Can you share some experience on management of pulmonary hemorrhage in premature babies?
Okay, I've come many times to Vietnam and given the talk on pulmonary hemorrhage. The baby gets pulmonary hemorrhage, then you should put the baby on high frequency ventilator or higher mean airway pressure. And you should give surfactant, and then you should correct the DIC, disseminated intravascular coagulation. They will need platelets. They will need fresh frozen plasma, sometimes they will need blood pressure support. In spite of all that, sometimes babies could die. We normally don't use intratracheal epinephrine. This is a study from Japan. They showed that you could dilute epinephrine and give it intratracheally in babies with pulmonary hemorrhage. But we use high mean airway pressure with a high frequency ventilator. We use platelets, and then we give surfactant to overcome the inactivation by the pulmonary hemorrhage. And if there is a PDA, then we try to close the PDA.
The next question is, for example, if we have a baby, the first dose of surfactant, we use Beractan, but after 12 hours, the baby requires second dose of surfactant. Can we choose another type of surfactant, for example, Porfactant?
I mean, you can, but there is no reason why you want to choose another surfactant. Yes, and same way, other way too. If your hospital doesn't have Kirosurf, and the baby gets referred from another hospital, but the baby got the first dose Kirosurf, now the baby needs the second dose. Can I use some other surfactant? The answer is yes.
Okay, so the next question is that we make a decision on giving surfactant based on the FiO2 requirement. But is there any difference if the babies babies have a full course of antenatal steroid compared to babies without antenatal steroid or not complete antenatal steroid? Is there a difference with the FiO2 criteria for surfactant between those groups?
No. Whether the mom got one dose or no dose or two doses, it really doesn't matter. If the baby has a requirement for FiO2 more than 0.30, that means baby has respiratory distress. There are some babies who will get respiratory distress. Antenatal corticosteroids decrease the incidence of RDS, right? It does not eliminate the risk for RDS. You still get RDS, but it's significantly reduced if the mother got antenatal corticosteroids, right? So if the baby's FiO2 requirement is more than 0.30, you should consider giving early rescue surfactant therapy.
Okay, we have come to our last question.
Okay.
Thank you for all your answers. I think everybody is very pleased with all of your answers here.
Thank you. I hope it's going to be helpful for your clinical practice. And you can always email me. You all have my emails, or Chewy can get me connected with you. You're all doing wonderful job in Vietnam. I know with the very limited resources, and lots of babies are born in your hospitals. Take good care of the babies and the families, and God bless all of you and your families.
All the questions finished? Okay, can I, on behalf of Hyphen, like to thank all the doctors. I think there are a few pharmacies to join this webinar that we arranged. I'd like to thank Professor Ram to wake up so early, 6 a.m. in the morning to do this, and Professor Kan Yong for moderator, and the two translators, Dr. Bin and Dr. Han. Thank you for all your good translation. I think it's a good success that we can share despite not being together. So thank you for everybody, and good night.
Good day for me.
Yes.
I hope
so Professor Kan
technically...
Yong, the second child is not due. Okay, that's good.
So technically it was all okay? Didn't get
Yes,
cut off?
I think it's okay because dual translation is quite good.
Okay.
Right, Ram?
Okay.
Thank you
Thank
very
you.
much. We keep
Thank
in
you
touch.
again.
Bye-bye.
Okay. Bye.
Bye-bye.
Please note to thank our scientific board speaker, Professor Ramanathan, for very exciting talk regarding resuscitation in preterm baby. And special thanks to Associate Professor Khánh Dung for engaging moderation. And thank you so much to translator today, PhD Thanh Bình and Dr. Thanh Hằng for help extending the story to life through your translation. Last but not least, thank everyone who make full your evening to join with us. Have a nice weekend.